dual antiplatelet therapy or dual pathway inhibition in patients with chronic coronary disease is a dilemma in our day-to-day clinical practice, and it's a controversy. DAPT for 1 year in ACS and beyond 1 year in high ischemic risk patients has been recommended by various trials and guidelines put forth by ESC, ACC, and AHA. However, in practice, we have observed that despite giving DAPT, some patients develop ischemic complications and some patients bleed. As a new concept has been emerged out, and that is DPI, dual pathway inhibition. It's inhibition of thrombin-mediated signaling process using a vascular dose of rivaroxaban in adjunct to antiplatelet therapy. This reduces atherothrombotic events in patients with stable coronary artery disease. Some patients are put to high ischemic risk because of some factors and these patients need extended antithrombotic therapy. So the factors which are responsible are, when you tackle at least 3 lesions in a patient, or you put at least 3 stents in a patient, when the total length of the stent is exceeding 60 millimeters, and when you have dealt with complex coronary artery disease, like you have tackled left main or calcific CTO or bifurcation, and when there is a history of stent thrombosis. The other factors which are responsible for high risk of ischemic events is multivessel disease, diabetes, recurrent MI, peripheral disease, heart failure, and CKD. So, in status post-MI in patients who have tolerated DAPT for 1 year, you can consider extending the therapy with either clopidogrel or ticagrelor. Of course, the dose of ticagrelor needs to be reduced to 60 milligrams twice a day. Status post-PCI for MI in patients who have tolerated DAPT for 1 year, you can consider extending it with prasugrel in the dose of either 10 milligrams or 5 milligrams, depending upon the age of the patient and weight of the patient. A new concept of giving rivaroxaban, this is the first and the only NOAC which has been recommended, 2A recommendation based on robust evidence from COMPASS trial in status post-MI, 1 year or multivessel disease. Dear friends, we know that in ACS patients with or without PCI, the platelet-mediated risk scores over thrombin-mediated risk. However, as the days pass off, months pass off, and years pass off, the risk of both platelet and thrombin-mediated risk goes down, but it is never abolished. In fact, in chronic cases, the risk of thrombin-mediated risk is little more compared to platelet-mediated risk. COMPASS trial in rivaroxaban with or without aspirin in stable cardiovascular disease. This has been published in 2017 in New England Journal of Medicine. And the objectives of the studies were to determine in stable cardiovascular disease whether rivaroxaban 2.5 milligram twice a day with aspirin or rivaroxaban alone 5 milligrams twice a day reduces primary endpoints compared with aspirin 100 milligrams. As many as 27,000 patients of stable coronary artery disease or peripheral vascular disease were included in the study, and in run-in phase, all the patients received aspirin. 3 arms were created. 1 arm received rivaroxaban 2.5 milligram twice a day with aspirin 100 milligrams once a day. Second arm received only rivaroxaban 5 milligrams BD, and the third arm received aspirin. In all the 3 arms, number of patients were more or less same. And the end of the study, 3 to 4 years, primary outcome of cardiovascular death, stroke, or myocardial infarction. Secondary outcomes in the form of cardiovascular death, ischemic stroke, myocardial infarction, acute limb ischemia or amputation, mortality were assessed, and even the net benefits and harm as far as the bleeding is concerned was assessed. Interestingly, it was observed that the primary outcome of cardiovascular death, stroke, or myocardial infarction was relatively reduced by 24% in the arm which received rivaroxaban 2.5 milligram twice a day and aspirin. And in the arm which received only rivaroxaban without aspirin, it did not significantly reduce the rate of MACE, but did increase the risk of bleeding. So after aspirin, COMPASS regimen is the first long-term antithrombotic to show the benefit as far as MACE and death is concerned. MACE was reduced by 24% and the death rate was reduced by 18% compared to only clopidogrel or aspirin. Incremental benefits in MACE reduction year after year were observed with this combination, and net clinical benefits were observed, and the less frequent severe bleeding was also observed in this particular combination. This trial was compared with Pegasus trial, which was again a landmark trial in which the patient received ticagrelor and aspirin. In COMPASS trial, patients of up to 20 years of MI were included, whereas in Pegasus it was up to 3 years. And a mix of PCI and non-PCI were included in COMPASS trial, both of coronary disease and peripheral vascular disease, and even some patients of stroke were included in COMPASS trial. In a subset with a history of MI, the outcomes of primary endpoint, cardiovascular death, MI, stroke, and mortality were significantly lower in the group which received dual pathway inhibition compared to DAPT, and of course the bleeding was a little more in DAPT group. COMPASS with or without PCI outcome, 26% relative risk reduction in MACE rates in patients with multivessel chronic coronary syndrome with or without primary PCI, and this observation was consistent irrespective of the year since PCI. Dear friends, which patients receive the maximum benefit? So those patients who are at the highest risk of getting atherothrombotic risk, they derive the maximum benefit. For example, 23 events were prevented per 1,000 patients over 30 months in the form of MACE, acute limb ischemia, or amputation when the risk was low. But as the risk was added to the patient, for example, if the patient had diabetes, in addition renal impairment, in addition heart failure, that means the risk was more, the maximum benefit was derived out of this combination. Significant absolute risk reduction was also noted in this particular group, and MACE rates were reduced by 3%, mortality was reduced by 1.3%, that was the absolute risk reduction, and the major bleeding absolute risk increment was only 1.2%. So higher the risk, more robust is the benefit. In subset of diabetic patients, the benefit and harm were compared in the various trials of antithrombotic therapy, and if you see, the number needed to treat in COMPASS trial were lower, only 43 patients to show the benefit compared to Pegasus and Themis, in which it was 67 to 125. And the ratio of number needed to treat and number needed to harm was less than 1 in COMPASS trial compared to Pegasus and Themis, it was more than 1. So after this, ADA in 2021 recommended the use of low-dose rivaroxaban plus aspirin in diabetic subset with chronic coronary syndrome and peripheral vascular disease with level A recommendation. Real life scenario, this is a patient with uncontrolled diabetes. He has been a smoker. He has a multivessel complex coronary disease, and he is receiving at the moment aspirin, ticagrelor, metformin, rosuvastatin, metoprolol, ramipril, and nicorandil. Obviously, the patient is at a very high risk, and he has tolerated DAPT, but he is definitely at more ischemic risk. So we need to modify the treatment, and the change that could be brought out is consider giving rivaroxaban to such patient in the dose of 2.5 milligram twice a day with aspirin, and of course dapagliflozin can be added. So the key point, this is my, many CCS patients remain at high risk for ischemic events. Patients with acute and chronic coronary syndromes have elevated long-term thrombin generation. In polyvascular patients, 33% relative risk reduction of MACE with rivaroxaban plus aspirin. COMPASS study includes and shown benefit in spectrum of disease profile compared to another previous. Rivaroxaban is recommended for long-term secondary prevention. So dear friends, one size doesn't fit all, and in a conflict between the heart and the brain, follow you have to heart, and knowledge becomes power only when we put into use. Thank you so much for your patient listening.